First of all, I just want to welcome you to Nursing 150. This is an exciting semester where a lot of the students begin to feel like they are learning nursing material, and on the clinical unit, they feel a little bit more functional and a little bit more involved in patient care. I encourage you to really embrace the knowledge and really embrace your clinical component and try to make sure that you put all the pieces together as you take care of patients on the floor. Some of the units have some very complex patients that will help you apply the knowledge that you're learning in your didactic component of this course. I really encourage you to take advantage of that. Take advantage of your clinical instructors, ask questions, and really try to put the didactic and the clinical component of this together. I think that will be key to your understanding. I look forward to a great semester, and this presentation is meant to kind of be a review of what you learned and some of the important pieces of what you learned about safety and the nursing, the role of a nurse as far as delegation, pre and post-op care of patients. You're going to be doing a lot of that this semester, so it's important to review that. So that is the intent of this presentation, is just to kind of walk back through that a little bit and pull out some of the important pieces of what you learned in Nursing 121 about safety, pre and post-op care, activity needs, things like that. The general role of the medical surgical nurse is to have an expanded knowledge and understanding of the patient as a whole. You're looking at larger concepts kind of that build on the basic concepts, the basic needs that you learned in fundamentals. Those concepts are related to your patient's psychological, cultural, spiritual needs, and their biological needs as well. Basic concepts we're talking about is safety, oxygenation, mobility, sensation, nutrition, elimination. Those basic concepts that you learned in fundamentals, we're going to kind of build on them based on certain body system and disease processes. And recent advances in healthcare have made the medical surgical nurses kind of require them to have a very vast knowledge. We're having sicker patients in the hospitals, so it's challenging the general nurse to really have a broad base of knowledge because they're going to be taking care of patients who are a lot more sick that are in the hospital. Dosage calculation is one of those challenges that have been put on nurses. They have to have a vast knowledge of being able to know lots of different meds and how to calculate specific doses. And that's kind of related to the next topic that we're going to talk about, which is safety. And you guys have all kind of known that we focus in this program on dosage calculation and as far as safe administration for our patients. So again, this presentation is just to review the role of the medical surgical nurse. You're about to embark on a semester full of knowledge that a med-surg nurse needs to know regarding their patients. It is a very vast amount of knowledge that a med-surg nurse needs to know about all kinds of different problems that might occur with your patient. The priority focus of a medical surgical nurse is safety and quality of care. We look at our patients and assess their situation and make sure when we talk about safety, we're talking about preventing them from injury. We're talking about safety as far as medication administration, making sure that we are administering their medication as ordered and that we are doing the proper nursing care prior to giving these medications. For example, if it's a blood pressure medication, we should check their blood pressure before giving a blood pressure medication. If it's a medication that we know might lower their heart rate, we make sure we check that heart rate before we give them that medication. That's all the safety as well. Prevention of illness. I believe you probably talked about some of these interventions that nurses can do to prevent illness in a patient. Prevention of illness means if they're in the hospital, we need to wash our hands. We need to teach them to wash their hands. We need to teach family members to wash their hands. We need to have them get up, move to prevent pneumonia. Get those Foley catheters out as soon as possible so that we prevent them from getting a urinary tract infection. We make sure that they're getting enough fluid intake. We do their eyes and nose. We monitor that to make sure they're getting enough fluid intake so that they remain hydrated and avoid getting a urinary tract infection. That is part of the role of a medical surgical nurse, to promote health, prevent illness. We meet basic patient needs, again, making sure they have enough food to eat, they have the proper food to eat, they're warm, they're well cared for. It goes way back to the philosophy of Florence Nightingale when she implemented, safe environment, a warm, dry environment to promote health. Dosage calculation. Make sure that's part of safety, really. That's part of safely administering medications, that we can do a dosage calculation accurately. And once you're on the clinical unit, you will note that we do dosage calculations daily. This isn't some kind of algebra that we're teaching you that you'll never use. You are going to use this on a daily basis. So it's important that we can safely do dosage calculation in order to make sure that we are delivering the medications safely and accurately to ensure health and prevent illness. Safety has become a very high priority within healthcare facilities, led by the Institute of Medicine in 2000 by putting out an initiative to prevent medical errors. Medical errors is one of the highest causes of death in the United States. In our country, we have a really high number as far as patient deaths that result from a preventable error. So all these institutions, Joint Commission, Institute of Medicine, there's many more, have put forth initiatives to make sure that we are practicing safe. We have safe evidence-based practice and are providing safe care to our patients and preventing any med errors. You've probably heard of the Joint Commission before. The Joint Commission is an accrediting body for healthcare facilities. It is a voluntary thing for a healthcare facility to have a Joint Commission accreditation. But what it's saying is that they have met standards that have been put forth by the Joint Commission. In order to be accredited by the Joint Commission, you have to meet a certain amount of standards. So basically what that says is to the public is that this facility has met the high standards of the Joint Commission and they are accredited by it. Joint Commission puts together every year National Patient Safety Goals. This can be found on their website if you want to look up the Joint Commission and look up the current National Patient Safety Goals. They come about this by their surveys that they do across the country and all the different facilities. And they find, basically, if they find a trend in med errors, safety errors, that such, things as falls. Recently we've had alarm safety, has been a National Patient Safety Goal. They find these trends across the country, and so the things that rank the highest in these trends of safety issues, of med error issues, and that's how they decide for the following year what's going to be their National Patient Safety Goal. So they sort of focus in on those trends that they're seeing across the country as an area of need where we need to focus as healthcare workers and fix these problems. And it's a lot of it's based, that's how we come about evidence-based practice. We don't just do things just because that's the way they always did it. We do it based on evidence, based on research, based on what we have found produces best patient outcomes. SBAR communication has kind of come about in the past probably 10 years, maybe more, and they are directly related to the Institute of Medicine issuing a need for safe care of patients. SBAR communication is a standard for communication between providers so that things are communicated well and that it decreases any safety issues with the patient and it increases good patient outcomes. Rapid response team is another initiative that came out of that Institute of Medicine report and from the Joint Commission. Rapid response teams were developed to decrease the amount of code situations that occur outside of the intensive care and also to produce better patient outcomes. They found that if we called in a team prior to a patient coding, then the outcomes for the patients were much better. It's important for the medical surgical nurse to understand what a rapid response team is, what the purpose is, and when to call them. And to be able to identify a patient that is starting to have a change, that has had a change in their status, and to know when to call for help prior to the patient getting to the point where they're in a code situation. If the med-surg nurse can identify this early and call the rapid response team, a team will come in. Usually what the members of the rapid response team are a critical care nurse, a resident or hospital physician, a respiratory therapist. And basically what they do is they come in and they are another set of eyes on this patient that can kind of assess the situation to determine what we need to do in order to get this patient out of this situation. Sometimes it might be maybe transferring them to another level of care. It might be having diagnostic tests done. It might be getting the doctor in, adding some medications such as different things like that. But they have found that since the initiation of the rapid response team in hospitals, that there has been a decreased amount of code situations and therefore better patient outcomes. There are several institutions that and healthcare organizations that help to promote safety. It's a big initiative. For the past 15 years, the IOM, which is the Institute of Medicine, has put out a lot of documents, a lot of reports saying the core things that we need to do as healthcare professionals to ensure the patient's safety and quality of care. And that includes, these are listed in your book. It's provide patient-centered care. So we talk to our patient. We look at a patient as an individual. And we look at their needs based on who they are, where they come from, what kind of diagnosis they have. We collaborate with the interdisciplinary team. We implement evidence-based practice. So what we know to be, there's evidence-based to what we do. We use quality improvement in patient care. We use informatics in patient care. Informatics is using an electronic medical record to look at our patient's history. We also use the electronic medical record when we're administering medications. We scan our patient. We scan their med. We look at the ID band. We make sure we have the right patient, the right route, all the 5 rights of a medication administration. So the Joint Commission is another institution that it comes into organizations such as our hospital that we do our clinical unit on, and they survey it every couple of years to make sure that they are meeting the standards set by the Joint Commission. Joint Commission has standards that focus on safety of the patient. Each year they do what's called the National Patient Safety Goals, and it's what they're looking for. When they come in and they do their survey of an organization, they have certain things that they focus on. Those are the National Patient Safety Goals. In the past few years, it's been a lot about falls, what we're doing for fall prevention. Also, anticoagulation. When we put a patient on a medication that makes their blood thin, we need to be doing proper education and proper monitoring of those patients. The rapid response team came about, it's probably been about 10 years ago, and it's a team that most of the hospitals in the area have put together. In the event that a nurse is taking care of a patient anywhere in the hospital, anywhere, and he or she has concerns that this patient is in trouble. It could be that maybe their vital signs are changing, they've spiked a temp, their blood pressure's dropping, something's changed in their patient. They are encouraged and taught to call a rapid response team. The rapid response team typically includes a pharmacist, respiratory therapist, a critical care nurse, and the house supervisor. It varies from institution to institution who is on a rapid response team, but 90% of these teams include a critical care nurse. It depends on who's around. Sometimes a resident will come, and a respiratory therapist. It's another set of eyes to put on this patient to say, okay, something's changed. What can we do now to prevent them from getting worse? It's basically kind of employing a team that comes in and says, okay, we need to do something quickly for this patient before we get into a code situation. Rapid response team was initially developed to prevent code situations outside of the intensive care unit. Sometimes it's just looking at a patient and saying, hey, they need a different level of care. We need to move from a med-surg floor to maybe a telemetry unit, things like that. Again, it's all about safety of the patient and preventing the patient from getting, health promotion, preventing illness. We always look at evidence-based practice to support everything that we do. It's always ongoing. It's the reasons why we do things that we do. It's the reason why we wash our hands between patients, because evidence has said if we wash our hands between each patient, we're going to prevent the spread of infection. And again, that's our role as a med-surg nurse, is to prevent illness. SBAR communication is an organized tool to use to communicate. It can be from shift to shift. So if you're, the off-going nurse doing their report to the ongoing nurse, if they use SBAR, which is situation, background, assessment, and recommendation, it is a way of organized communication. You can use it for talking to a provider on the phone if there's been a change in the patient. You can use it if you're giving handoff to a different unit, if the patient is being transferred to a different unit, if the patient is being transferred to a different facility. It's a way of organized communication. And we're going to do a lot of practice with SBAR communication in our activities in class. Delegation is a very important skill that the medical surgical nurse needs to understand for various reasons. We know that a nurse is kind of tasked throughout the day with doing several things, and the nurse has to learn how to be able to delegate tasks that can be delegated to unlicensed professionals in a safe way. In order for everything to be able, all the patients' needs to be met, they need to be able to delegate, but they need to be able to do it effectively and safely. The biggest thing that a nurse needs to understand is that only the task and not the accountability is delegated. So, and the important thing to think about, important principles of delegation, is the fact that the nurse is still accountable for the task, and they need to have that person that they delegated the task to report back to them and let them know the outcome, that it was done, that it went well, and that basically, for example, if you delegate to a PCA or patient care assistant to do a blood pressure, you need to make sure that it was done. The nurse would then need to follow up in the computer and make sure that it was documented. And if there are any issues with the blood pressure, if it's too high or too low, the nurse is responsible and accountable for that blood pressure, not the person that it was delegated to. Every state has a Nurse Practice Act, which identifies the tasks that are legally and safely delegated. There are the 5 rights of delegation, which is the right task, right circumstance, the right person, the right communication, and the right supervision. You need to make sure that you follow up and make sure that they did the vital signs, and look at what, it's not their responsibility. If they're abnormal, it is not the PCA's responsibility to do something about it. It is yours. So you follow up with that person to make sure that they were done, and if they were done, were they normal? If they weren't normal, it's your role to follow up on those abnormal vital signs. Chapter 16 and 18 in Module 1 cover pre-op and post-op teaching for a patient, for a medical surgical patient undergoing some kind of a procedure. It also talks about discharge teaching for a procedure. Some of this is probably a bit of a review for, from your fundamentals, but make sure you review these chapters especially regarding informed consent. Have an understanding of what informed consent is and what the nurse's role in informed consent is. Basically, it's never the nurse's role to explain the risk and benefits of the procedure. The physician performing the procedure, it is their responsibility to make sure they explain the procedure and any risk factors, side effects, things like that. And it is the nurse's role to go ahead and have the patient sign the informed consent, and the nurse will witness that the patient signed it and had an understanding. If there are any questions regarding the procedure, if the patient has any doubts, issues, concerns, they need to have a conversation with the physician again. So it's basically just the nurse's role to witness that the patient signed that they consent for the procedure, not to explain the procedure. Pre-op and post-op teaching occurs immediately when someone is scheduled for a procedure. Preoperatively, there's a lot of diagnostic tests that are routinely ordered. Chest x-ray, basic labs, CBC, metabolic panel are common ones. Make sure you have an understanding of why we do that. And it's typically to get a baseline or to identify if somebody is already at risk. If we do a chest x-ray and somebody already has some pulmonary compromise, they may not do the procedure due to the pulmonary compromise, or they'll just go in having the knowledge that they're going to have to be a little bit more careful with this patient, especially post-operatively. Also, pre-op labs are determined, make sure somebody is not anemic, make sure they have a good blood count, if there's going to be blood loss during the procedure. Lots of different reasons, and like I said, a lot of times it's just to do a baseline. Preoperative care is also entails identifying a patient that has risk factors for complications postoperatively. A lot of that has to do with their age, any medications they're on, any significant medical history, diabetic, if they've had heart disease in the past, any pulmonary disease in the past typically puts somebody at risk for postoperative complications. So that's a big part of the nurse's role is to do that pre-op assessment, a history, and to identify anybody at risk for postoperative complications of a procedure. One thing to note is on page 244 in your book, in your IGGI book, it's table 16.4. It talks about all your herbals and all your naturals. Want to make sure, a lot of people forget to mention these as a daily medication. So we need to make sure that we ask questions if they've been on any herbals or natural treatments for any kind of conditions. Some of them can make them at risk for bleeding if they've been taking it, and they might need to stop taking it in advance to the procedure. Postoperative care is a huge job of a medical surgical nurse. We are aware of any complications that the patient might be at risk for, so that would be require having a knowledge of their baseline condition and being ready to prevent any post-op complications. Post-op complications include infection, and mobility, decreased mobility, pulmonary complications. So there's a lot. The biggest job of the medical surgical nurse in this situation is prevention of any of the post-op complications, and there's a lot of different strategies that we use. The incentive spirometer is a big one for pulmonary toileting to prevent any pulmonary complications, monitoring any wounds for signs and symptoms of infection, monitoring vital signs for any abnormalities, any post-op complications is a big, big job of a medical surgical nurse for a post-op patient. Another big job is teaching the patient, how to change their mobility, the importance of doing their incentive spirometer, and then also teaching them what to expect when they go home. So discharge teaching. And that discharge teaching is going to start immediately when somebody's scheduled for a procedure. They try to start getting that already talking about what's going to happen at discharge. And that's also talking about what to look for, what, as far as signs and symptoms of infection, when to call the doctor, when their follow-up appointment is. It's very important to teach this and so that the patient is compliant. Postoperative patients need education regarding dressing changes that they might have to do at home. They also need education on pain management. They might be sent home on certain pain medications that they're going to have an understanding of how to take them and how to manage them. They need to understand any side effects of this pain medicine, such as constipation, any drowsiness that it might cause. They might not be able to drive. All those instructions post-operatively. They also might have devices, drainage devices. They might have to have some education on how to manage those. A lot of times it's very important to add a family member in the discharge teaching, because a lot of times if the patient is in pain or if they're stressed, they don't really hear what you're saying and they might not be able to remember what you tell them. It's always a good thing to put it in writing for the patient and the family member, so that they are able to remember when they get home and are by themselves. It's good for them to have a number to call to make sure they can, call if there's any worries or concerns. Backing up to postoperative care of the medical surgical nurse when a patient immediately arrives to the unit after a surgery. They've typically spent some time in the PACU, which is the post-anesthesia unit, and then they arrive to the floor after they've been stabilized. But always make sure initially, especially in the first 24 hours after a surgery, that you monitor their vital signs more frequently. You monitor their airway because they've typically been under some kind of anesthesia, and you want to make sure that they're waking up and breathing okay. The other thing is monitoring for any bleeding from any wounds, so check those wounds pretty frequently, especially in the first 24 hours. Gastrointestinal complications can be constipation, so always kind of monitor those bowel sounds. Typically, they don't have bowel sounds if they've had general anesthesia for about 24 hours. But we always monitor for the return of bowel sounds and return of an appetite, and a return of passing flatus, things like that, in order to make sure that their GI tract has woken up from the anesthesia and they don't have any complications that way. Also, going to monitor for urinary output to make sure that their kidneys are doing okay and that they're getting enough fluid. This concludes the video presentation for Module 1. Be sure to review Chapters 1, 16, and 18 in your IGGI Medical Surgical book. You also have other resources, including your NCLEX RN exam review. I look forward to reviewing this content further in class with you. One of the most important roles of a medical surgical nurse, or really any nurse, is education. We teach our patients a lot. We help them take care of themselves through teaching them the things that they need to know how to take care of themselves. Pre and post-op teaching is a huge thing that you will see done when you go to your clinical units. We need to teach them preoperatively about what to expect, how to prepare for whatever procedure they're having. Do they need to not eat before the test? Do they need to have some testing done preoperatively? Post-op teaching begins preoperatively if we can. So preoperatively, we already start going ahead and teaching them about what's going to happen postoperatively and the things that they need to be doing postoperatively. For example, if someone is coming in for a hip replacement, we will teach them about what's going to happen postoperatively. You're going to be using a walker. We're going to get you up right away. We're going to ask you to get up, cough and deep breathe. Because again, remember the role of a medical surgical nurse is to prevent illness. We want you to cough and deep breathe to prevent pneumonia. We are going to get you up and moving to promote circulation, to promote healing. We're going to start physical therapy, again, to promote and prevent. That's a lot of what we teach. We'll teach them about pain medication. Yes, there will be some pain involved in this procedure. However, I can give you medication, and I'm going to need you to communicate to me when you're in pain so that I can medicate you appropriately. Postoperatively, again, continues with making sure that they understand wound care, if there's a wound involved in the procedure, what to report, what abnormals to report. If you spike a temp, you should call us. If you have drainage from your wound, you need to call us. All of those things, it's very important that the nurse communicates that well to the patient because it can be a life-saving education. If you teach them and you teach them well, you could save their life by, if there's a problem that occurs and they call because they remember what you told you. That's how important it is. This teaching, this medication, understanding what medications they're taking can save someone's life. So it's a huge, important piece of nursing. Obtaining informed consent is always done preoperatively. Make sure you're familiar with what the nurse's role is in informed consent. That means that when we have a patient signed an informed consent form, that they verbalize to us that they understand the procedure that they are about to go under and that they agree to it. It is not the responsibility of the nurse to explain the procedure or tell them exactly the risk involved. That's the provider that is performing the procedure. What we do is clarify. If they have a question, they say, hey, am I really going to have to cough and deep breathe after the procedure? He said I'm going to have to get up the next day and cough and deep breathe. And you say, yes, that is correct. You can clarify, but it is not the role of the nurse to really explain what's going to happen. The surgeon or the provider that's doing the procedure is. When you have a patient sign a informed consent, you are simply witnessing that it is indeed the patient that's signing it and that the patient says, yes, I got this. I understand this. I'm going to sign the paper. Make sure you understand what that means, what the nurse's role in an informed consent is. NCLEX exams and HESI exams seem to like questions about that, what our role is. So make sure you're familiar with that. Preop lab and diagnostic tests. There's a lot of things that we look at if a patient is going into a procedure. We want to make sure that they can safely undergo the procedure without any complications. So a lot of times we'll check their blood count, we'll check their kidney function, we'll check their liver function to make different things like that to make sure that we have a good baseline of where the patient stands before the procedure, and if the patient can tolerate the procedure. If they already have an elevated white blood count and they've already got some kind of infection going on, we don't need to be going in there and cutting them open because they've already got some kind of infectious process going on. So that's why we'll do a lot of pre-op labs before we put someone under in a procedure to make sure that they're not going to have complications with the procedure. The nurse's role for all of these is to make sure that they are done. It is not your role to interpret them completely, but to make sure that they are done. And if there are abnormals that come up, if a lab comes up and it's flagged as abnormal, or the lab calls you and says, hey, this white blood count was really high, it's your responsibility to make sure that that gets called to the provider, and then the provider will make the decision from there. Prepping these patients for diagnostic tests. If it's an MRI, if it's an X-ray, if it's a more invasive procedure, we need to know how to prep our patients for all these diagnostic tests. That's the nurse's role. It's not our role to decide which diagnostic tests they should have. Our role is to make sure if a provider orders a diagnostic test, that we know how to prep the patient for that. If they're not supposed to eat 4 hours prior to a test, we need to know that. Those are things that we're going to talk about throughout the semester. We're going to talk about each diagnostic test is appropriate for the disease process that we're talking about at the time. We also are going to do some activities in clinical to kind of review these diagnostic tests, to look at what they're for, how we prep a patient for them, and so forth. I hope this has been a good review of the role of a medical surgical nurse. All of these concepts that we discussed for this presentation are all going to be kind of scattered throughout Nursing 150, and hopefully you're comfortable with the content so far, and we will continue to expand on what you know about these concepts.